All right, what's up? Kenan Omurtag, Lightboard videos, recurrent pregnancy loss, the approach to treatment. This varies widely and has everything to do with pacing. Every patient who walks into a fertility clinic, credit to the patient, you know who you are, who told me about the importance of the word pace, is very important because for some folks, the option is just keep trying, use an ovulation prediction kit, timed intercourse. Other folks, we're ready to just do IVF with or without pre-implantation genetic testing. If we think it's an embryo problem and we think it's a chromosomal problem with the embryo, I guess we'll just keep doing genetic testing, or we'll do genetic testing to make sure the embryos are normal. So we need to do IVF. And then there's everything in between, from using Clomid and artificial insemination to using injectable medications. And that's not to mention the adjuncts like progesterone support. Okay? So you'll notice these are all fertility treatments. And that's important to point out. A lot of folks, again, with recurrent pregnancy loss do not have infertility. Some patients do have infertility. But it's important to talk about the folks with recurrent pregnancy loss, depending on how long they've been struggling to have a live birth, what their history is. Some folks maybe just want to be aggressive and pursue fertility treatments just to augment their chances of getting pregnant in a given cycle. So a lot of times we'll start with simple treatments like ovulation prediction kit, timed intercourse for 3 to 6 months. Sometimes we'll just do Clomid alone for 3 to 6 months. Again, depending on the age of the patient, how aggressive they want to be, and the rest of their history. So there's a lot of variation here. Talk to your physician. Obviously, if you're going to start doing this stuff, you need to see a fertility specialist. Some OBGYNs will feel comfortable just giving you clomiphene, but others will say, nah, you need to go see a fertility specialist. For the folks who are doing ovulation prediction kit and who are interested in progesterone support, usually the people that may benefit from the addition of progesterone have had 3 or more consecutive losses. There may be a role for progesterone supplementation. Anytime you do progesterone supplementation, I typically recommend a vaginal suppository. There is good data to suggest that vaginal progesterone has better absorption. And then I usually like to start at 5 days after an LH surge. Because if you give progesterone too soon, you'll prevent ovulation. So you don't want to do that. So we wait 5, and some might say 7 days post LH surge. So if you're using an ovulation prediction kit, 5 to 7 days after that kit is positive, start vaginal progesterone. And again, talk to your doctor about the specifics. Notice we're starting it before you get pregnant. So there is some evidence in patients who have bleeding in early pregnancy where starting the progesterone vaginally is beneficial. We still don't have a lot of great data about whether it is better to start the progesterone in the luteal phase in the days after you ovulate, or if it's okay to just start it at the time of pregnancy, positive pregnancy test. But there is some thought that starting it sooner may be better. So that's why I like to personally, again, start it 5 to 7 days. But again, everyone's a little bit different. There isn't great data pushing us one way or the other. So again, talk to your physician about what's best for you. Some folks will say, I keep having these losses. Can I just do some simple fertility treatments like Clomid? The rationale for that is, these people don't have infertility. They just, for whatever reason, are kicking off eggs that result in embryos that don't implant or eventually arrest and result in miscarriage. So a lot of folks, some logic goes, if I can do Clomid and super ovulate and release multiple eggs, at least one of those eggs is going to be normal and result in ongoing clinical pregnancy and ultimately live birth. Again, a lot of this stuff is not studied head to head, so there isn't one right way or wrong way. That's why we're talking about the approach to treatment, because everyone's approach to treatment is highly individualized. Patient highly individualized, physician highly individualized. So I think it's important to recognize that these are all options. Some people may even add in IUI, some people may add in injectables, and again, some people may go straight to IVF and genetic testing. Watch those videos on how IVF works to learn more about that, and how pre-implantation genetic testing works to learn more about that. The jury is still out whether patients with recurrent pregnancy loss do better with IVF alone versus IVF plus PGT, especially given their age. If they're younger, under 35 versus over 35, there's a tremendous amount of nuance in those conversations. I'm not even going to pretend to get into it here. That's not what we're here for. Again, we're here just to do a general approach of recurrent pregnancy loss treatment. And again, this goes back to what I said earlier. Most people, if you do nothing, if you just keep trying for a little bit longer, you will eventually hit the mark and get that embryo that continues to grow and results in live birth. Let's talk a little bit, let's end on some supplements. So you'll hear, I alluded to it earlier, you'll hear people talk about supplementation. Do I need to be on this or that supplement to reduce the chances of recurrent loss? I mean, we usually tell people, prenatal vitamin with 800 micrograms of folic acid. Again, this is where people start to wonder, oh, is there a difference between folate and folic acid? There are some differences, but they are not clinically significant. So someone taking folic acid versus folate, the data would show you, and I make this statement based on the fact that a head-to-head trial in patients with MTHFR mutations did not demonstrate any difference in their pregnancy loss outcomes, whether they took folic acid or folate. So it doesn't matter. The cost of the two is pretty much the same. So if you already have purchased a bunch of folate, keep taking it. If you haven't, and you're wondering if you should, but you've got all this folic acid, that's fine too. Probably not going to make a difference in your overall outcome. I recommend fish oil. Fish oil has been well documented as a good anti-inflammatory and associated with pregnancy, and if you're allergic to fish, can't take fish, then a flaxseed oil is fine. Basically, you want to take an omega-3 fatty acid. And then vitamin D3 supplementation, which is the most common, is 2,000 IUs, is also associated with pregnancy. So these are not necessarily treatments or supplements for recurrent pregnancy loss per se, but just a general, for anybody out there who's trying to conceive, just supplements that I recommend. The approach to treatment in recurrent pregnancy loss is very complicated, but can be complicated, but highly individualized. So again, I can't say it enough. Talk to your physician about what's right for you. But no, ultimately, even if you did nothing, there's still a good chance you will have a live birth. It may not feel like it in the moment, but the chances are very good. If you've had a prior live birth and you have subsequent recurrent losses, if you did nothing, you have about a 50 to 55% chance of live birth. If you've never had a live birth and you have recurrent losses, maybe a 40% chance of having a live birth with a subsequent pregnancy test. So again, you are not broken. This process can still work for you. See a reproductive endocrinologist if you'd like to learn more about what your options are for taking back some control of the process. Thanks for watching, and I hope you enjoy this series.